Good morning, everybody. I'm very happy to join you today in this Italian campus in its second day. I hope this second day will be as fruitful and successful as the first day was. Today we have two sessions. I'll manage to get into the first session. We have two distinguished speakers. To cut story short, we'll introduce the first speaker, Professor Paolo Buzzoli, and his presentation is insight is innovation, technology, and the management of type 1 diabetes. Professor Paolo Bozzoli from the Italian group of the campus. We'll give him 20 minutes, and if we have questions, we'll allow 10 minutes for discussion.
Ladies and gentlemen, I'm going to talk about innovation, technology, and the management of type 1 diabetes. This is my disclosure. There is no question that technology has highly impacted the management of insulin-treated diabetes over the past few years. And there has been a major advances in the management of patients that are treated with insulin to improve their metabolic control. Historically, our group in Rome was the first to use continuous subcutaneous insulin infusion at the time of diagnosis of type 1 diabetes. We published this work in Diabetes Technology and Therapeutics in 2003, nearly 20 years ago. And we were able to demonstrate that patients that were treated with the CSII for 2 years compared to patients receiving classical subcutaneous insulin infusion had a better residual beta cell function. That is, as we know, an important parameter to take into account, in particular in patients with recent onset of type 1 diabetes. Over the years, the evolution in insulin infusion therapy has been remarkable. And as you can see here, we are moving from the first augmented sensor to the pumps that suspend on low, suspend before low, the hybrid closed loop, and the personalized closed loop for the automatic meal control. And more we have now pumps that have fantastic opportunity to keep the patient with their blood glucose in time in range. But I think that this position statement that we publish on the Italian experience, it is relevant in understanding that use of pumps and giving all information to patients needs to be done correctly, and in particular with people that are knowledgeable and skilled to use pumps for managing type 1 diabetes. So these centers, there should be center of excellence, should be knowledgeable on the pump models currently available to offer patients the best possible pump personalized for the patient. So just to give you an example, we cannot consider the same level very young patients and patients above the age of 50 because technology, the technology approach to pump, it is not so easy for patients that are not digitally well knowledgeable. Then the patient center should be a center with not only a specialized physician into pump therapy, but also a nurse and dietitian, and therefore are available around in the office in order to make the patient the best possible way to learn how to deal with the pump. And then the educational program. There should be a structured educational activity, and in particular, training patients about carbohydrate counting, and also to provide a 24-hour access to medical assistance at least in the first 2 weeks after implementation of the pump. If we look at the results of trials, there have been several trials that use pump versus multiple daily injection, and that is a meta-analysis published a few years ago in Diabetes Metabolic Research Reviews. You can see the overall patients on pumps have reached a better metabolic control, and in particular, this is true for patients that are over 18 years of age, and suggesting that use of pump is definitely now a way to consider for patients with type 1 diabetes. Also, another aspect that we should keep in mind is the cost effectiveness of sensor augmented pump therapy in populations with type 1 diabetes, and that they use different systems. So for instance, this paper, we look at patients that use an integrated system, pump plus real-time glucose monitoring, and patients with insulin pump therapy alone. And if we look at the cost that that are taken into account for reducing hypoglycemia events, you can see that by reducing hypo-hospitalization, you can actually save nearly 3,000 euro for each avoided event, and reduce access to the emergency room also can be substantially reducing costs. And regarding the optimization of metabolic control to reduce diabetic complication, long-term diabetic complication, you can see that it's been calculated that approximately 12,000 euros are saved for an avoided cardiovascular disease event, just considering only the first year of treatment. And these are other events that can be prevented using pump. And as you can see, there is substantial saving in money for using the insulin infusion pumps. And also, we have to consider that we may reduce productivity losses and improve quality of life. And definitely, it is a good investment to provide patients with type 1 diabetes with a pump. Having a look at what the recent technology offer to patients with type 1 diabetes, I think particular interest has been given to the MiniMed 670G, the 670G hybrid closed loop. That was the first FDA-approved system in the US, patients with type 1 diabetes above the age of 14. The system has shown in pivotal trials to be very efficient in obtaining metabolic control. Basically, when it is in auto mode, basal insulin delivery is fully automated, and then the insulin infusion is targeted to have a blood glucose level of 120 milligram deciliter. The control algorithm consists of a sensor glucose value. The active insulin is given to patient, and then the insulin active time and the insulin to carbohydrate ratio can be adjusted in manual or auto mode. And the auto mode, the insulin sensitivity factor is algorithm controlled, and this is another great advantage. And the system will learn the insulin requirement over time by using information of the previous few days. What about the pivotal trial? The pivotal trial includes subjects with age 1475 in total. The pediatric age was 713, and also in patients with 2 to 6 years of age. There were several centers that were taken into account for this study, and there was a period of run-in with the CGM and with the pump, and then the 3 months follow-up period with the smart card, and then patients were on automatic control over the period of follow-up. This is the pivotal trial adolescent and adult population. You can see that the HbA1c levels decreased from 7.7 to 7.1, and was highly significant. And the proportion of patients that were in target moved from 60.4 to 67.2 time in range. and that is the adolescent population. In the adult population, there was a decrease of glycated hemoglobin from 7.3 to 6.8, and there was an increase of the time in range from 68% to 73.8, that is above the 70% range to say that the patient is well controlled. As you know, the time in range is now a very attractive new parameter to say, in addition to glycated hemoglobin, that the patient is well controlled, and is now well defined by the major societies that a time in range above 70% is considered to be excellent for patients with type 1 diabetes. So in conclusion, the pivotal trial indicates that the system is safe, able to improve glycemic control without severe hypoglycemia, diabetic ketoacidosis, or serious device-related adverse events. Now, of course, one thing is the pivotal trial and one thing is real life. Now, this is a study retrospective that was recently published on 3,000 patients, more than 3,000 patients. You have the population here, including also patients with an age range 22 to 60, that was the large majority, even patients greater than 60 years of age. So they were not young patients, very familiar with technology. And as you can see, the real life results, you have a large number of patients that have a time in range, the average was 71.4, so indicating that the use of this system definitely helps patients in different population age to reach optimal metabolic control. And then you see here the results, in particular from the manual mode was 66% versus the auto mode, so very helpful, this information, that was 71.4. If you look at the time spent with target below 70, the hypoglycemia, you can see that the manual mode was 2.7, in auto mode was 2.1, so well below the 4%. That usually is the one that you find in patients with multiple daily injection. And the time spent above target greater than 180 was 31, and then down to 24%, so slightly above the range of 20%. So overall, the real life results confirm the pivotal trial results, showing that we can obtain optimal metabolic control in patients using this 670 pump. The results in real life results show here, confirm the clinical results of the pivotal trial, and then you can see we reached 72.6 in the pivotal trial and 71.4 in the real life with the Smart Guard Auto Mode. And now I have the remaining minutes for my presentation devoted to see how technology has improved metabolic control in patients with type 1 diabetes. Now, this is the effect of COVID-19 lockdown on glucose control using continuous glucose monitoring and using pump. And definitely there is no question that the COVID-19 lockdown has been an unprecedented model to investigate how acute changes in lifestyle may affect glucose control in diabetes. So here we have patients that were on ambulatory glucose metric defined according to the consensus of time in range, and they used the continuous glucose monitoring. And from the 14 days preceding the lockdown that started in Italy at the beginning of March, 10 of March. So that was the period before the lockdown. And then they were under control of lockdown from 10 of March to 25th of March, with the extension of lockdown to the whole of Italy in people that were treated either with multiple daily injection or CSII. This is the effect of lockdown on the glucose profile. As you can see, this is the time in range, this is the time above range, this is the time below range, the hypoglycemic events, and the time below range in patients with baseline time below range greater than 4%. So these are patients with frequent hypoglycemia. And as you can see, the results overall here, there was no difference before lockdown and during lockdown. But interestingly, the patients that were monitored carefully during lockdown had the reduction in the number of hypoglycemia. And so the number of hypoglycemia and then obtain an excellent metabolic control with less hypoglycemia using this continuous profile. And here you have the change in time below range during lockdown compared to the time below range at baseline. You see this is significant. And then the change of hypoglycemia length during lockdown was reduced, and the change of hypoglycemia events during lockdown was not significant, but there was a tendency for a better metabolic control with less hypoglycemia. Possibly the explanation is that the lockdown has forced people to slow down their routine and therefore resulting in increased time to better control glucose trends and to provide a faster response to hypoglycemia, as suggested by the results of the exploratory subgroup analysis. And also the type and length of physical exercise might have changed the potential risk of hypoglycemia and therefore reducing hypoglycemia. The role of in-home physical activity also, it is of interest in this other paper looking at glycemic control during COVID-19 quarantine. Here you have the system, the study showing that the metabolic control in adolescents using intensive glucose control monitoring did not worsen during the restriction due to COVID-19 pandemics, and then improved, and that is quite interesting because it's significant, improving those that continued physical exercise during the quarantine. So, of course, the regular physical activity during quarantine for some people was not easy, but indeed during this study you can see that there is an improvement of the time in range in patients that were doing physical exercise during the quarantine. And then, as you can see here, this is the time in range without the auto mode, this is with auto mode. And as you can see, there is definitely a much better metabolic control obtained during the phase of physical exercise. Finally, I'm going to show you the experience in our center with patients with type 1 diabetes on CSII, and these are unpublished data. This is what's happening in our clinic, in our center. 31% of all population of patients type 1 diabetes are on pump, compared with 69% that are in multiple daily injection. And above those that are in therapy, you can see how many are on the pump with continuative use, and those use the sensor augmented therapy only intermittent use. And these are the percentage. If we look at the patient age group, you can see that we have that this is the total number of patients, and you see that the number of patients that have CSII tend to be more in those that have the pump in patients greater than less than 30 years of age, have more use of pump, being younger. And of course, this is the way how we treat young patients that like very much to have the pump, compared to patients greater than 50 years of age, where the majority still prefer to be treated with the multiple daily injection. And this is very likely due to the fact that technology is not for everybody. The patients that from a pediatric center came to our center in the period between January 2015 and June 2018 were 112. And then you can see here how we move patients to pump and improve their metabolic control in a very short period of time. You see, this is how we got our patient from a pediatric center with 7.8, 7.9. And then within 6 months, their metabolic control improved considerably. And this is a demonstration that changing patient to pump is a way to improve metabolic control for those that come from pediatric clinic. And this is the experience in our center, looking at the therapy before transition, and then 6 months after transition, you can see that we have increased by 11% the number of patients in our population that move to pumps. And I think this is a critical age where we should pay much attention in order to improve metabolic control when we receive this patient that change completely their attitude coming to an adult center compared to what was before their life in a pediatric center with their parents. So I'm going to conclude by saying that the way how we change our treatment during COVID-19 pandemic definitely taught us a lot about the relevance of technology and how technology can help in obtaining an improvement in metabolic control. And there is no question that the cover of the Endocrine Society talking about the rise of telehealth during COVID-19 and virtual endocrinology and doctor online, we can say diabetologists online. And I think that more and more we'll have diabetologists online, that in particular in patients with type 1 diabetes will need to be followed up rapidly with doctors using mobile devices and be in touch constantly with their patients. So I conclude by saying that the new generation type 1 diabetes subject is a digitally advanced patient that have a greater compliance to treatment, develop much less chronic complication, and its quality of life will be greatly enhanced, also as consequence of novel technology that is associated with smart devices for glucose management. So it's an exciting time, ladies and gentlemen, and we definitely are going to move forward very fast in this area, and I'm sure that our diabetic patients will enjoy more and more being treated with this high technology for their hyperglycemia. Thank you very much for your attention.
تفتح الكاميرا.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد رسول الله وعلى كل المرسلين. كل سنة وحضراتكم بخير. معاكم أشرف طلعت، أنا أستاذ الباطنة وغدد سماعة بكلية طب دمياط وجامعة دمياط. Now هتبقى المذر تانج هيبقى الإنجليش. I will be here. Next. We have a novel guidelines for managing LEDA, which means LADA.
I should thank Professor Paolo for his updated, excellent talk regarding technology in type 1 patient control. Paolo stressed on the idea of time in range in control of type 1 diabetic patients. He commented on the condition under COVID-19 pandemic, and astonishingly enough, he remarked that situation is better. Probably patients are concentrating and doing some physical exercise in their homes. Also, Paolo shared his experience in the center that he is the head of. Thank you, Paolo. And now we'll move to our next speaker, Professor Dr. Ashraf Talad, a senior professor of diabetes and internal medicine, and he is currently the dean of the Faculty of Medicine in Dumyat University, as I understood. I have known Professor Ashraf Talad for a long time. He is a dear friend and a real professor. Please, Professor Ashraf.
Bismillah ar-Rahman ar-Rahim.
He will give a hint on the LADA, an interesting subject. تفضل.
Bismillah ar-Rahman ar-Rahim والصلاة والسلام على سيد رسول الله. Thank you, my dear Professor, Dr. Bahrawi, for your kind words and beautiful statements. You say, I think that Dr. Bahrawi is the biggest figure all over our country and in Alexandria and in the field of diabetes. I suppose to meet him, inshallah, closely. My presentation is a novel guidelines for managing LADA. LADA is the latent autoimmune diabetes in adult. Next. Italian Diabetes Campus, we are really happy to be in this virtual meeting to discuss the recent and updated presentations or trials in the field of the diabetes. Next. As you know, that the diabetes is a huge underground problem all over, that the area of the Middle East is doubling, will be the numbers of the people, estimated people with diabetes. And all over the world is also, it will be increasing to about 2040 to 642 million people with diabetes. Next. As you know, the glycemia and the complication of diabetes, including macrovascular and the microvascular complications, and the macrovascular complication increase the mortality through cerebrovascular diseases, coronary artery diseases, atherosclerosis, or peripheral vascular disease. And also, microvascular complication, the impairment of cognitions and the diabetic retinopathy and diabetic nephropathy, also neuropathy, all diabetic food with increase the morbidity. Next. LADA, this is another type of diabetes. This kind of condition is typically incorrectly diagnosed and sometimes misunderstood. And honestly, there happen to be many doctors who might be unfamiliar with it. Next. Next. LADA typically is found in the individuals who are 35 to 50 years of age. All of these people most often have a couple of the characteristics associated with type 1, even though the age range of them have a tendency to be informed that they have type 2. Somewhere around 10% of diabetes sufferers truly have LADA, meaning it may possibly be more common when compared with type 1 diabetes. What's more, with anyone that has been diagnosed to have, what is LADA? The term latent immune diabetes in adult is used more commonly than slow diabetes or diabetes 1.5, and is probably a more accurate description. LADA is generally classified as a subtype of diabetes mellitus type 1, although recent research suggested that is not exactly correct because LADA has some characteristics of diabetes mellitus, thus diabetes 1.5. The onset of LADA is slower than diabetes mellitus type 1, thus slow diabetes. And LADA is clearly not the same as a diabetes mellitus type 2, which is characterized by insulin resistance and occurs primarily in the older adults. Also, there has been an increase in the children diagnosed with type 2, probably because of increased rates of obesity. Next. Next. Yes, with autoimmune diabetes type 1 or LADA, beta cells are destroyed. So researchers believe that autoantibodies trigger a response by T cells, which in turn attack and destroy the beta cell. With LADA, it appears that some protective immune response slows destructions of beta cell in comparison with the rapid destruction found with typical diabetes mellitus type 1. Next. LADA is sometimes misdiagnosed as type 2 diabetes, and some scientists have indicated that 1/10 to almost 1/3 of the people diagnosed with type 2 are actually living with LADA. Next. Why some people with LADA are misdiagnosed with type 2? Like type 2 diabetes, individuals with LADA initially don't experience insulin dependency at the first. So also, individuals with LADA typically develop the condition in their 13s, while growing a number of children are developing type 2. The majority of people living with type 2 develop diabetes as adults. Also, individuals with LADA typically experience insulin resistance like individuals with type 2 diabetes. Like type 2 diabetes mellitus, people with LADA frequently have high glucagon values, and also individuals who have been misdiagnosed with type 2 diabetes have not been tested for autoantibodies that are associated with type 1 diabetes mellitus, and this is the sole way to verify if a patient is truly have a LADA. Next. How do LADA and diabetes mellitus type 2 differ? In front of us, there is a slide which shows us the characteristics of the LADA and type 2 diabetes. Patients with LADA tend to be lower body mass index, but it is does not true for all adults because those diagnosed at older age may be some weight gain. The most important one in this, that the usual age of onset is LADA is from 30 to 50, with also there is no family history of diabetes mellitus, and the time of onset of symptoms to insulin dependency, it takes from 2 to 4 years, but in the diabetes mellitus type 2, it takes 8 to 10 years. The presence of central obesity and the metabolic syndrome, it is absent in the LADA, but it is present in the type 2 diabetes mellitus. Next. Main similarities between LADA and the type 1 diabetes, both conditions are autoimmune disease that lead to insulin dependency, and individuals with either condition frequently possess a normal body weight or may unintentionally lose weight. Next. This is the ecological classifications of diabetes, which is so that it may be insulin deficient or insulin deficient and resistant. But in the immune deficient is type 1, there is type 1A immune mediated, which includes LADA in between it. So the autoimmune polyendocrine syndrome and human leukocytic antigen and also immune deficiency and polyendocrinopathy and enteropathy X-linked. This is present also in the insulin deficiency immune mediated. But in the insulin deficient and resistance, we have two types, which is monogenic type or polygenic type, and the monogenic type is include type 2. But the monogenic type is the MODY type, maturity insulin diabetes of the young, or permanent neonatal diabetes mellitus, which is BNGM, and this is the size of the genetic abnormality. Also, you must know, next, the autoantibody test for type 1 is islet cell cytoplasmic antibodies, which is called ECA, and glutamic acid decarboxylase antibodies is GADA, and the insulinoma-associated type autoantibodies IAA2A and insulin autoantibodies IAA. So the top of the two, which is islet cell cytoplasmic autoantibodies ECA, is diagnosed in 70 to 80% of those newly diagnosed with type 2, and also GADA is positive in 70 to 80% of newly diagnosed with type 2. Next. This is another classifying of diabetes according to HLA system and according to the positivity or the negativity with the associations of autoantibodies IAA, GADA, IAA2A, or zinc transporter 8 autoantibodies. This considered that almost autoimmune negative at the onset. We measure the C-peptide if it is more than 1 or less than 1. Less than 1 and subcategorized to blue 0.03 to 3.03 to 0.07. And these classifications is told us about the abnormalities, which is blended as the severity of the insulin deficiency in secretion from the pancreas. Next. There is a broad characteristics of LADA. What is mean that the age is around 30 or more, family history of autoimmune, there is no metabolic syndrome associated with type 2, lower HOMA, lower body mass index, lower blood pressures, no disease-specific difference in the cardiovascular outcomes between these patients. C-peptide level decrease more slowly in type 1. But the positivity of GADA as the most sensitive marker, there is other autoantibodies least frequent. So non-insulin requiring at the onset of diabetes, it is a characteristic of the pictures of LADA. Next, the diagnosis is autoantibodies in the blood. Adult onset, no need of insulin or more than equal 6 months after the onset of the symptoms. So autoantibody tests are commonly used to differentiate between type 1 and type 2. Next. So autoantibodies tests are commonly used to differentiate between type 1 and type 2. ECA, GADA, IA2A are all associated with distractions of the beta cell in the pancreas and suggests that an autoimmune process is taking place. Both the presence of GADA and the ECA antibodies are predictive of insulin dependency, but GADA is the most predictive. Next. So the diagnosis to be fulfilled, the study shows that 80% of those diagnosed with diabetes type 2, but with a positive GADA, progress to insulin dependency within 6 years. And also, some genetic tests have confirmed that LADA, especially human leukocyte antigen, HLA type, and also another test can be helped to differentiate between LADA from diabetes and type 2 is C-peptide test. Next. How can I treat? The basic therapy of diet and weight loss, if necessary, and exercise is the cornerstone of both LADA and diabetes type 2. Because LADA is frequently misdiagnosed as diabetes mellitus type 2, the approach to treatment is often the same. One problem is that initial treatments of diabetes mellitus type 2 may work well, leading to physicians to believe the diagnosis is correct. However, the improvement may be short-lived. Next. Which told us ADA-CD guidelines recommendation in this management of these situations. Next. You must do screening of GADA, and then screening is negative, it is a type 2. But maybe suspect that the LADA, especially if lean or other autoimmune disease, you must action screen of IA insulinoma associated to autoantibodies. If positive, measure the serum C-peptide. If the serum C-peptide is below 0.3 nanomole per liter, this or between the 0.3 to 0.6 nanomole, this is a gray area. This is LADA algorithm applied. If more than C-peptide, more than 0.7 nanomole, type 2 ADA-CD guidelines is applied. Next. So C-peptide is less than 0.3 nanomole. This is an insulin, basal or prandial and or prandial. If it is between 0.3 and 0.7 nanomole, use metformin first and reassess every month, 6 months. No issue, no issue, no issue. Apply the ADA and the ACD guidelines. Indicator, patient at high risk and the patients with low risk. Patient with high risk with established atherosclerotic cardiovascular disease or chronic kidney disease, which predominate atherosclerotic cardiovascular disease, predominate GLP-1 with proven cardiovascular disease benefit. or SGLT2 inhibitors proven cardiovascular benefit is estimated. GFR is adequate and the body mass index is more than 72 kilogram per square meter. And this is considered potential insulin requirement and the risk of the future deterioration and ketoacidosis. Number 3 is basal insulin in the combination GLP-1 or SGLT2 in the presence of hemoglobin A1C more than 9. If it is not above the target, you must note insulin basal bolus. The second one is heart failure or chronic kidney disease predominates. SGLT2 inhibitor with proven cardiovascular benefits. If the estimated eGFR are inadequate and another the same criteria, if it is above the target, keep ADA guidelines, but delete SU. In the cases of without established atherosclerotic cardiovascular disease, you have 4 drugs: DPP-4 inhibitors and GLP-1 receptor agonists and sodium glucose transporter 2 inhibitors and TZDs. There is no preferable drug for the other, but you must, from this algorithm of glucose lowering medication in LADA patients with C-peptide without established atherosclerotic cardiovascular disease or sporadic kidney disease, deviation from ADA-ACD type 2 diabetes algorithm, there is increase in diabetic ketoacidosis, especially with SGLT2. You must take care from this area and you must consider that estimated GFR is adequate and the amount you must be used in this area is taken with carefully for the patients, but there is trials which uses of DPP or inhibitors and TZDs with a success in proving that this drug is suitable for LADA. Next. One of this, next please. Next. Yes, one of the research or a paper which is published with the combined treatment with sitagliptin and vitamin D in a patients with latent autoimmune diabetes in the adults. This is a case study. Next. They found that both vitamin D analogs and DPP-4 inhibitors have been shown to improve beta cell function and attenuate autoimmunity in diabetes. To our knowledge, this is the first case of combined treatment in a patient with LADA that resulted in reverting the phenotype and preserving excellent glycol without the use of insulin 24 months after initial diagnosis. Next. This also the management of latent autoimmune diabetes in adults and the consensus statement from an international expert panel. This is the use of sodium glucose co-transporter 2 inhibitor, and the panel concluded that the approved use of SGLT2 in post type 2 and selected type 1 patient, those overweight, suggested that this may be promising agent in LADA. However, no studies have been performed in LADA, and attention should be paid to ketoacidosis in patients with medium to low C-peptide level. Next. This also original articles from denoting that long-term risk of cardiovascular disease in the individuals with latent autoimmune diabetes in adults, UPDS. The aim of this is, if the latent autoimmune diabetes in adult LADA is diagnosed up to 12% of adults with clinically diagnosed type 2, LADA tends to have a healthier cardiovascular risk profile than type 2. But it remains uncertain where the risk of cardiovascular event differs between the two. So they concluded that in the adult,
So to have newly diagnosed type 2, the long-term risk of MACE was lower in those with LADA. However, didn't differ after adjustment for traditional cardiovascular risk factors, suggesting that measurement of autoantibodies in addition to traditional cardiovascular risk will not aid in stratifications of the cardiovascular risk in the clinically diagnosed type 2 diabetes. Lastly, this is a preventive strategy and evidence-based interventions that make sense. You must change individual levels through exercise and the lifestyle modifications, and also the media and the community and the population being to alert them the presence of LADA in between type 2 diabetes, and you must to do some lab investigation to suggest or prove that the LADA is absent in the type 2. My conclusion is diabetes mellitus is a major challenge to human health. And also type 2 diabetes mellitus can be prevented. But the primary prevention is a suitable and affordable choice. And also screening of the persons with diabetes above 30 years for diabetes autoantibodies is essential to diagnose LADA. And the treatment of LADA according to C-peptide level and also according to ADA-CD guidelines should be addressed. There is a strong evidence that lifestyle interventions are effective in diabetes control early. LADA is present among type 2 diabetes mellitus. You must search for it carefully. And finally, thank you very much. Next. Next.
Thank you, Professor Ashraf Talad, for this very excellent overview of the subject on LADA, diagnosis and treatment. And as you mentioned, most cases are mixed up with type 2 patients, and you gave a hint on when to suspect a case of LADA and how to confirm the diagnosis. And you delineated clearly that we should depend on the investigation using the C-peptide and
Yes.
the autoantibodies.
Yes.
Thank you very much, Professor Talad. And because we are running out of time, we'll have to conclude this session and go on to the next session. May I call the moderator, Professor Samir, and the speakers. Thank you.
Everybody, it's my great pleasure and honor to call upon Professor Frara Stefano, who will talk about a very interesting subject, SGLT2 inhibitors, the updates. Please, Professor Stefano.
Dear Chairman, thank you so much for your kind presentation, and let me thank again the organizing committee. The topic today is actually really intriguing since we are treating the most innovative drug class for diabetes. And I'm gonna show you that SGLT2 inhibitors are actually useful not only in diabetic patients to treat and reach adequate glycated hemoglobins. So starting from physiology, we know that SGLT2 inhibitors block the sodium glucose cotransporter at the proximal tubule. And this is responsible for the reabsorption of both sodium and glucose. At the same time, the content within the renal tubule, so the pre-urine, is hyperosmolar, in particular when the SGLT2 inhibitors are effective, and draw water from the outside into the tubule with increased diuresis. The more sodium reaches the macula densa, the most appropriate is the signal we know that macula densa acts as a chemoreceptor, and so is a sort of a chemical sensor specialized in detecting the concentration of sodium in the tubules. A reduction in systemic blood pressure is perceived by the macula densa as a reduction in systolic blood pressure, since in this case, normally, the excretion of urine sodium is reduced. The macula densa then sends signals to the extraglomerular cells that leads to an increase in renin production, triggering a mechanism that ultimately leads to an increase in blood pressure. You know that renin has an important function in regulating blood pressure and is involved in the physiological processes that induce also arterial hypertension and renal failure. Therefore, when renin is reduced, we can imagine that the intraglomerular pressure has a positive effect on the kidney. At the same time, stimulating the glucosuric effects, we are losing daily an amount of about 70 grams of sugar, of glucose. And so this means around 300 kilocalories per day. And so we know that SGLT2 are effective, and all the free actually available drugs, so canagliflozin, dapagliflozin, and empagliflozin, are effective both as monotherapy and as an add-on therapy when metformin alone or together with sulfonylurea or pioglitazone are not effective in controlling the glycemic profile of our patients. But thinking about the physiological mechanisms, we can imagine, of course, that SGLT2 inhibitors are effective in reducing glycated hemoglobin, but at the same time, they are able to reduce also the fasting plasma glucose of a mean of around 15, 20, up to 40, 50 milligram per deciliter. And once again, when we are treating our patients, most of type 2 diabetic patients are obese. And so what about the BMI, so the body mass index and weight? We have all the free drugs are effective in reducing weight, and this is coming from a review that we have published just a couple of weeks ago, and showing mean weight changes when we are prescribing only as an add-on therapy SGLT2 inhibitors, a reduction of up to 4.7% of the total body weight. That means a reduction of around 3 to 4 kilograms as a mean in our patients. But at the same time, we know that there are selective inhibition of sodium glucose cotransporter in the proximal tubule, reduce glucose and sodium reabsorption, leading to multiple beneficial effects. Of course, it reduces hyperglycemia, and at the same time may ameliorate the glucotoxicity, in particular at the renal and pancreas level, reducing the insulin resistance and improving the beta cell function. And as we have just seen before in the previous slide, we can observe a reduction in body weight. But beyond the effects on glucose, the combination of osmotic diuresis and natriuresis following SGLT2 inhibitors prescription may mediate changes in sodium handling, leading to reduced plasma volume, preferentially from the interstitial space, and result in a reduction of blood pressure. The effects of SGLT2 inhibitors on sodium also has a beneficial implication for excess glomerular pressure and filtration. And so a number of direct and indirect effects of SGLT2 inhibitors may contribute to preventing or at least delaying the progressive decline in renal function that we can observe in patients with or without diabetic nephropathy. SGLT2 inhibition leads to an increased distal delivery of sodium to the macula densa, which induced afferent arterial vasoconstriction, resulting in decreased glomerular hydrostatic pressure and hyperfiltration via tubuloglomerular feedback. Inappropriate activation of the renin-angiotensin-aldosterone system is a critical factor in the pathogenesis of the renal disorder associated with diabetes, and changes in sodium and water with the prescription of SGLT2 inhibitors do not seem to be associated with a compensatory increase of the renin-aldosterone activity. Evidence from models coming from in vivo study suggests that a reduction in biomarker of inflammation and fibrosis was clearly associated with SGLT2 inhibitors may improve renal function, and SGLT2 mediated increases in hematocrit may improving once again hypoxia. And so this combined with the reduction in both sodium and solute transport demand may alleviate hypoxia and resultant ischemic injuries. These effects are manifested in the clinical presentation as a stabilization of the estimated glomerular filtration rate, decreased blood pressure, and decreased albuminuria. I'm sorry. In type 2 diabetes, chronic hyperglycemia leads to an enhanced SGLT2 activity, which results in an increased glucose reabsorption along with sodium. The juxtaglomerular apparatus, so at the macula densa level, perceive this as a low effective circulating volume condition, leading to an afferent renal vasodilatory response and so hyperfiltration. The main renoprotective effect of the SGLT2 inhibitors is thought to be mediated by restoring delivery of sodium to the macula densa. SGLT2 induce an initial decline in glomerular filtrate during the first weeks of treatment, but this is followed by a stabilization in the estimated glomerular filtrate on longer studies. Since renal function decreases during the natural course of the diabetic kidney disease, this pattern may indicate that SGLT2 inhibitors provide long-term nephroprotection. Combining as SGLT2 inhibitors with an angiotensin-converting enzyme inhibitor, which reduce, of course, the intraglomerular pressure and hyperfiltration by inducing vasodilatation of efferent renal arterioles, may be particularly effective in preventing progression of diabetic nephropathy. Chronic activation of the sympathetic nervous system is a hallmark of several clinical conditions, including ischemic heart disease, heart failure, hypertension, but also kidney disease and type 2 diabetes per se. Renal stress due to the increased reabsorption of glucose by the proximal tubules results in increased renal afferent activity, which ultimately leads to increased afferent sympathetic outflow to the heart, to the blood vessels, and finally to the kidneys. Chronic sympathetic activation is not only a risk factor for the development of hypertension, but also has detrimental effects on the kidney and vasculature, resulting in increased arterial stiffness, endothelial dysfunction, and altered sodium and water homeostasis. Tubulo-interstitial lesions characterized by a thickening of the tubular basement membrane, tubular atrophy, interstitial fibrosis, and chronic inflammatory processes are commonly observed in patients with type 2 diabetes and both chronic kidney disease. There is also evidence that suggests that renal epithelial cells exposed to stress or injury can undergo a morphological conversion to fibroblasts, thereby contributing to the pathogenesis of kidney fibrosis. In this case, SGLT2 inhibitors may reduce fibrosis, and at the same time, when we are evaluating the decreased renal workload that is associated with hypoxia, we can observe how much SGLT2 are effective in preventing the hypoxic ischemic processes, and so the hypoxia-induced proximal tubular damage. At the same time, chronic kidney disease, defined as a reduction in estimated glomerular filtrate or the presence of micro and macroalbuminuria, is a common event in patients with diabetes. And glomerular hyperfiltration in diabetes precedes the onset of microalbuminuria and decline of the renal function, of course. SGLT2 inhibitors have been associated with a substantial reduction in albuminuria and reduced the risk of progression to macroalbuminuria. At the same time, they were effective in indirectly improve morbidity and mortality, given the association of kidney disease with the increased heart failure and mortality risk. And so we can move to hypertension, that is another factor contributing to the poor cardiovascular outcomes in patients with diabetes. We know that hypertension coexists frequently in patients with diabetes, and more than we can imagine, we can estimate that more than half of patients with type 2 diabetes also are hypertensive. And therefore, this further worsen the cardiovascular aspects health of our patients. And several studies have demonstrated the beneficial effects of controlling cardiovascular risk factors in patients with diabetes to reduce cardiovascular events. And according to a series of meta-analyses, treatment with SGLT2 inhibitors in patients with diabetes may lower systolic blood pressure and diastolic blood pressure in a significant way. The rapid decrease in plasma volume mediated by SGLT2 inhibitor is thought to be an important mechanism underlying the improvement in heart failure outcomes observed in a series of studies with this as a primary or secondary endpoints, and these are all clinical trials related to SGLT2 inhibitors. Data from different studies also show that SGLT2 inhibitors exert nephroprotection by different mechanisms, such as restoring tubuloglomerular feedback, thus decreasing hyperfiltration and therefore albuminuria, and directly decreasing the tubular injury. In addition to these renal hemodynamic effects, SGLT2 inhibitors also have inhibitory effect on the inflammation and fibrotic processes, as we have seen before. And treatment with dapagliflozin, for example, has been shown in several small clinical studies to decrease biomarker of renal injury, and of course to significantly reduce microalbuminuria. Hypoxia inducible factor 1 is a key protein that regulates adaptive cellular responses to hypoxia in the kidney and several other organs. Erythropoiesis, we know that starts from kidneys. It is one of the several biological processes that are associated with normal renal function. Recent in vitro studies show that dapagliflozin induce HIF1 in murine ischemic renal tissue and human ischemic cultured renal tubular cells, and reduce the apoptotic cell death. Dapagliflozin pretreatment significantly elevate the expression of hypoxia-inducible factor 1, reducing the level of serum creatinine and decreasing lowering the ratio of the resistance to apoptosis. Elevation of hematocrit after initiation of SGLT2 therapy in patients with type 2 diabetes may be viewed as a surrogate marker of a reduction of the metabolic stress on the proximal tubules, and has been shown to be closely linked to a reduction in cardiovascular mortality in large clinical trials evaluating SGLT2 inhibitors in patients with type 2 diabetes. So, putting together all these molecular and finally clinical effects, improving the cardiac contractility and improving the blood pressure control, we can affirm that SGLT2 inhibitors plays a direct and positive effect as a protective factors for myocardial injury and heart failure. In fact, we know that coming from epidemiological data in a series of different population studies, this is, for example, coming from Sweden, we can observe that death from caused by cardiovascular disease and in particular heart attack is significantly higher in patients with type 2 diabetes as compared to controls without diabetes. And the rate of decline is, as we can see here, is slowing. So we can say we are no more effective in treating complications for diabetes, in preventing diabetes. No, I don't think this is the right message, but the mortality reduction that has been observed, clearly observed for both major cardiovascular events and atherosclerosis has not been yet observed for heart failure and arrhythmia in last years. In fact, myocardial damage with a dysfunction of both left ventricular, both diastolic and systolic ventricular damage is an early and often undiagnosed complication in patients with type 2 diabetes. We need to, this is particularly interesting since 5 years after the diagnosis of type 2 diabetes, more than 2 in 3 patients has evidence of left ventricular dysfunction. But at the same time, if we are screening our patients without any sign of myocardial damage, so no angina, no alteration at the electrocardiography, actually the heart failure could be diagnosed in up to 1 in 4 patients with new diagnosis of type 2 diabetes. And once again, the mortality rate, so one of the ardent point for diabetes is still too high. 1/3 of patients that are hospitalized for heart failure and diabetes died within 1 year. And this didn't change through the last 10, 20 years. We know that actually the decline in renal function is strictly associated with incident heart failure. And this is particularly true, we can see this both in patients with microalbuminuria and reduced ejection fractures. And this could be also evidenced in patients with a reduction of the glomerular filtrate. So we can say that this strict link between renal, kidney, and cardiovascular disease is in some way linked all together. And we need to remember that patients with chronic kidney disorders and diabetes are at higher risk for death due to cardiovascular events than dialysis, and so end-stage renal disorder. And this is particularly interesting that because when we are thinking about diabetic microvascular complication, we know that one of the most common is the end-stage renal disorder. But at the same time, we need to prevent this final condition, and at the same time taking in mind that the risk of death for cardiovascular events is still higher than the risk of dialysis. We can see what happened in the last 20, 30 years about major cardiovascular events, including myocardial infarction, stroke, and amputations. So we have an improvement of all these rates, and the new drugs have actually showed a significant effect, positive effect on mortality for cardiovascular event and heart failure. And in particular, SGLT2 inhibitors together with GLP-1 receptor agonists have been associated recently with a significantly lower mortality for cardiovascular event and heart failure as compared to healthy controls and patients treated with DPP-4 inhibitors. And so this is data coming from canagliflozin, and this is the results of the Credence study when it was prescribed for both primary and secondary prevention of cardiovascular events. We can see that the hazard ratio was significantly lower for those patients treated with canagliflozin. And that was significant just after just a little bit later than 2 years of treatment. That was particularly true for both cardiovascular death and hospitalization for heart failure. Let's move to a real-world trial when we can observe also the effects of dapagliflozin. In this study, patients were enrolled from 6 different countries with a total of almost 1.5 million people, so a very huge numbers of patients with type 2 diabetes that were new users for SGLT2 inhibitors. They were all less than 10% of patients were included in each of the SGLT2 inhibitor and cohort group study. And we can observe also in this study that the cumulative incidence for major cardiovascular events and hospitalization is significantly lower in patients treated with dapagliflozin as compared to the DPP-4 inhibitors. And so let's move to the broadest, largest, and longest SGLT2 inhibitor study, which is the DECLARE study. This has been published a couple of years ago, and it is actually really interesting since providing data about different endpoints, including death for cardiovascular disorders, myocardial infarction, stroke, and also hospitalization for heart failure. And looking at the data that have been published so far, we can observe that even in patients that were classified as a low risk for cardiovascular events, those treated with dapagliflozin showed a significant reduction of both hospitalization for heart failure, a significant reduction for death due to cardiovascular major events, and at the same time, a significant reduction of all the major cardiovascular events. Dapagliflozin at the same time prevents hospitalizations in patients with type 2 diabetes, and that was independent from the established presence of cardiovascular disease, and at the same time, this was independent from the previous diagnosis of heart failure. So dapagliflozin should be used probably not only to treat patients with an already established cardiovascular disorder, but or heart failure, but also to prevent acute events. In fact, dapagliflozin was able to preserve the kidney function in patients with type 2 diabetes and normal renal function at baseline. We know that we have a slow decline, we have seen it before, a slow decline of the kidney function in patients with diabetes. And dapagliflozin was effective in reducing this decline. And the nephroprotective effects were similar in all the groups stratified for cardiovascular risk. So independently of the high, very high or moderate cardiovascular risk, dapagliflozin showed effectiveness as a kidney protective drug. At the same time, a slightly lower reduction, and this is interesting, has been also reported for all the causes of death in patients with type 2 diabetes that were at high risk of cardiovascular events that were treated with dapagliflozin as compared to placebo. So in conclusion, we can say that selective inhibition of the SGLT2 receptor at the proximal tubule level I'm so sorry, significantly reduces the glucose and sodium reabsorption, leading to a series of beneficial effects. that are sometimes beyond the effects on glucose. And the combination of osmotic diuresis and natriuresis that is associated with the treatment with SGLT2 inhibitors may reduce plasma volume and therefore guarantee a better control of arterial hypertension. A series of possible different mechanisms have been proposed to explain this cardio and renal protection that we have seen in the previous slides, and that were associated with the treatment with SGLT2 inhibitors. One, the cardiac mechanisms that cause a reduction in both preload, afterload, and left ventricular wall stress, improving the filling conditions with a final improvement in myocardial energy, and the renal mechanisms with a reduction in the glucose sodium reabsorption that cause changes in intraglomerular pressures, an improvement in the intrarenal renin-angiotensin activity, hyperfiltration, and inflammation or hypoxia. And finally, circulatory mechanisms together with the reduction in plasma volume and blood pressure. The DECLARE study is actually one of the largest studies that evaluate cardiovascular outcomes of SGLT2 inhibitors in patients with diabetes, clearly and finally defining the cardiorenal benefits of this class of antidiabetic drugs. The DECLARE study confirmed that dapagliflozin is both cardio and nephroprotective, and therefore this conclusively demonstrated that dapagliflozin consistently prevents hospitalization for heart failure in a large population of type 2 diabetic patients, regardless of previous history of cardiovascular disease or heart failure. At the same time, SGLT2 inhibitors are able to reduce the major cardiovascular events in type 2 diabetic with an established atherosclerotic cardiovascular disease, but is able also to improve the progression of kidney disease, and so reduce the progression of kidney disease in all the patients treated with SGLT2 inhibitors. Therefore, the early use of dapagliflozin in type 2 diabetes not only controls the patient glycated hemoglobin, but could be also prevent cardiovascular disorder and the progression of kidney disease, together with a significant reduction of heart failure that needs hospitalization. And I thank all of you for the attention, the endocrinology unit of the San Raffaele Hospital and the Institute of the Endocrine and Metabolic Sciences. Thanks once again to everyone.
Thank you very much, Professor Stefano, for a wonderful expose, including both the molecular biology aspect and its clinical implication. I don't see questions, but we are not late now, so I can ask one question, please.
Yeah.
As you know, the lower the eGFR and the higher albuminuria are both strongly associated with cardiovascular event, kidney failure, and mortality. Unfortunately, in the insert leaflet of most pharmaceutical companies dealing with SGLT2, they put a cutoff point not lower than 60 estimated GFR, very rarely 45. But you are aware certainly of the 2021 KDIGO consensus, and I quote here, SGLT2 inhibitors should be initiated if the eGFR is equal or above 30 milliliter and can be continued through the eGFR below M30 until dialysis. So in your experience, in your practice, how low you go with the eGFR in patients.
You are completely right, but I think in this case we need to maintain what are the indications for the drugs. I completely agree with you. All these indications coming from, for example, in Italy, from the European Medical Agency, suggests to stop SGLT2 inhibitors with a filtration lower than 45 and to reduce the doses among 45 and 60. But probably these are the specific subset that may have the better prognosis in terms of cardiovascular events and heart failure. We need to remember, you are completely right, that these patients may have not only chronic complication, but this chronic complication led the patient to acute events. They further compromise their quality of life, of course, and the health, the well-being perception, together with all the problems that we are thinking about, the biochemical exams, the radiological exams, and so on. So I agree with you. I think the problem is related to the approval of these drugs that is now, we can say, a bit outdated and should be revised according to the next and more recent evidence about these drugs and the effectiveness of these drugs in patients with diabetes. And probably we can talk about patients without diabetes. We have discovered a drug that probably, for instance, is effective in patients with diabetes, but that could be beneficial even in patients that doesn't need to reduce their glycemic levels.
Thank you. Thank you very much, professors. Thank you.
You're
So
right.
we end our this one small session to reconvene.
Thanks a lot.
Reconvene again. It's my great pleasure to call upon my dear colleague, friend, and brother, Professor Talad, the ex-head of our unit and our department, who will talk about a very updated topic, the 2021 ADA standard of care for management of hyperglycemia in type 2 diabetes. Please, Professor Talad.
بسم الله الرحمن الرحيم. شكرا أستاذ سمير for this nice introduction. Good evening for all. I would like to thank all the organizing committee and all my professor and colleague in our department and all distinguished speakers in this wave. And I hope to see all again in the second wave. After the excellent presentation done by Professor Stefano, the role of SGLT2 inhibitor in the cardiac and renal protection, the guidelines had been changed. ADA 20 and 21, the first, we should assess the patient characteristic. We have two arms. The arm those with complication and the arm those without complication. Those with complication, either with established atherosclerotic cardiovascular disease or indicator for a high risk for cardiovascular disease, we should use SGLT2 inhibitor regardless the baseline A1C. Dapagliflozin has proven cardiovascular benefit. The second issue, patient with heart failure, particularly with reduced ejection fraction, the same regardless the baseline A1C, metformin plus dapagliflozin. Dapa is the only SGLT2 inhibitor has proven benefit for reduction of heart failure. The third, diabetic kidney disease with albuminuria. Regardless the baseline A1C or individualization of A1C target, dapagliflozin or canagliflozin. DAPA has a primary evidence for reducing CKD progression and has been shown to reduce CKD progression in the cardiovascular ongoing trial. These for the patient with complication. The second arm is patient without complication. If we need to minimize hypoglycemia, SGLT2 inhibitor are indicated. If we want to minimize the weight, the same SGLT2 inhibitor are indicated. This is for EDA 21. The second for ACC or AACE, with ACE algorithm for glycemic management. Here also we have individualization of the target according to these items. Here the accept A1C less than 6.5 for patient without concurrent serious illness. For patient with concurrent serious illness, they accept more than 6.5. This is for glycemic target. How to reach to this target? The first, lifestyle modification, then independent on the glycemic control. Patient with established or at a high risk for atherosclerotic cardiovascular disease, they recommend SGLT2 inhibitor or GLP-1 agonist. In patients without these, according to the A1C level, if A1C less than 7.5, they recommend monotherapy. From 6.5 up to 9, they recommend dual therapy. More than 9, if the patient is symptomatic, they recommend insulin plus other agent. If no symptom, they recommend triple therapy. For monotherapy, we have one of the choice is SGLT2. For dual therapy, the same. One of the choice is SGLT2. For triple therapy, one of the choice is SGLT2. These in patient without established atherosclerotic cardiovascular disease. The third guideline or the third recommendation is the primary care physician. For this primary care, they divide the patient into two groups according to risk stratification. Patient with a very high risk for cardiovascular disease, like history of cardiovascular disease or multiple uncontrolled cardiovascular risk factor, or estimated GFR less than 60, or albuminuria for any degree, or diabetes start before the age of 40 years. These with very high cardiovascular risk, either atherosclerotic cardiovascular disease, heart failure, or CKD, or high cardiovascular risk. They recommend to use SGLT2 inhibitor or GLP-1 for patients with atherosclerotic cardiovascular disease alongside at the same setting rather than stepwise. They recommend combination therapy from the beginning for those with atherosclerotic cardiovascular disease. The same for heart failure. Consider SGLT2 alongside rather than stepwise approach. For CKD, the same. If the estimated GFR more than 30, consider SGL2 alongside rather than stepwise approach. So for this, with a very high risk, we choose alongside at the same setting. For a high cardiovascular risk, second line after metformin. The same again. SGL2 inhibitor in heart failure beyond glycemic control. SGL2 inhibitor DABA, IMBA, and CANA should be recommended to reduce the risk of heart failure in patients with type 2 and either established cardiovascular or high risk for cardiovascular disease. The same, DABA could be considered in the treatment of the patient with heart failure with reduced ejection fraction with and without type 2 diabetes. يبقى ده beyond glycemic control. And then I can use in patient with heart failure, either diabetic or non-diabetic. DABA and IMBA are recommended to reduce the combined risk for heart failure and cardiovascular death in symptomatic patients with heart failure reduced ejection fraction. Also, consensus to minimize or to optimize the treatment of heart failure. Here is SGL2 inhibitor, one of the line of treatment of heart failure with diuretic, hydralazine, ivabradine, and RAS blockade. You see, SGL2 inhibitor for use in patient meeting the estimated GFR. DABA more than 30, IMBA more than 20 for treatment of heart failure with or without diabetes. Also in pre-diabetes. Pre-diabetes had been discussed elegantly by Professor Iman Yusuf yesterday, but also in the consensus of the European Society of Cardiology guidelines on diabetes and pre-diabetes and cardiovascular disease. As we see, if you have drug-naive patient with atherosclerotic cardiovascular disease, or high risk or very high risk for cardiovascular disease, you can start by SGL2 inhibitor prior to metformin or GLP-1. قبل الميتفورمين European Society of Cardiology. لو عيان drug naive, if a patient on metformin, you can add after that. Type 2 on metformin with atherosclerotic cardiovascular disease or high risk for developing cardiovascular disease. The same. We add either SGL2 inhibitor or GLP-1. يبقى drug naive, I can start without metformin. Patient with on metformin, we can add SGL2 inhibitor for their cardiac protection. Also, risk reduction, so primary or secondary prevention, SGL2 inhibitor with demonstrated cardiovascular benefit are recommended for patients with atherosclerotic cardiovascular disease or heart failure or diabetic kidney disease. Also, for cardiovascular risk reduction, SGL2 inhibitor in patients with atherosclerotic cardiovascular disease or heart failure or diabetic kidney disease. Don't start SGL2 inhibitor in pregnant or breastfeeding woman or estimated GFR less than 30. This is for cardiovascular risk reduction. The same for primary prevention of cardiovascular disease. We have secondary prevention. We have reduction in hospitalization for heart failure. We have treatment for heart failure. Also for primary prevention of cardiovascular disease. A1C more than 6.5. As we see, dietary, exercise, aggressive treatment of the cardiovascular risk factor, consider metformin. If we reach to the target, we'll end good. If we don't reach to the target, we add SGLT2 inhibitor or GLP-1 agonist. This for primary prevention of cardiovascular disease. Now we come to diabetic kidney disease. We finish cardiovascular, we come to diabetic kidney disease. As we see, diabetic kidney disease, urinary albumin creat more than 30, estimated GFR, urinary albumin creat more than 300, estimated GFR more than 30, we use SGLT2 inhibitor at first, prior to GLP-1. If the GFR or estimated GFR يسمح, we start by SGLT2 inhibitor. If GFR less than 30, we use GLP-1 agonist. طيب. لو في high risk for heart failure, we use SGLT2 inhibitor. If atherosclerotic cardiovascular disease هي ال high risk, use GLP-1 أو SGLT2 inhibitor. urinary albumin creat ratio أقل من 299 واستيميتد GFR more than 30 SGLT2 inhibitor أو GLP-1. يبقى SGLT2 inhibitor preferred. لو GFR less than 30 يبقى GLP-1. يبقى ده الالجوريزم for treatment of the patient with CKD, diabetic kidney disease. Lastly, this is the algorithm summary for KDIGO diabetes management. طب glycemic target وبنبدأ بلايف ستايل وبعدين بنحط أدوية. ميتفورمين لو كان الجي اف ار بيسمح بالنسبه للميتفورمين، ميتفورمين عند استيميتد جي اف ار اقل من 45 بنقلل الدوز النص، عند 30 اي شود ستوب ميتفورمين. نفس الكلام SGLT2 انهبيتور لما نستخدمها مع الميتفورمين جي اف ار اكتر من 30، اقل من 30 دونت انيشيت SGLT2 انهبيتور. لو اقل من 30 we can use GLP-1 هنا preferred، او ممكن اخد DPP-4 inhibitor with adjustment of the dose، او insulin with adjustment of the dose، او sulfonylurea like gliclazide او glipizide they don't need adjustment of the dose. TZDs don't need adjustment of the dose, but the problem of TZDs is salt and water retention with osteoporosis, which are very common in patients with CKD. Lastly, I can use alpha glucosidase inhibitor without dose adjustment. This is the management for the patient with CKD. Lifestyle modification, metformin if the GFR allow. If the GFR not allowed, we can use SGLT2 inhibitor. If the GFR not allowed, we can use GLP-1 or DPP-4 with adjustment of the dose, insulin adjustment of the dose, sulfonylurea we know the safest, TZDs try to avoid, and alpha glucosidase inhibitor. Lastly, my conclusion is most of the guidelines recommend the use of SGLT2 inhibitor in patients with atherosclerotic cardiovascular disease or high risk for atherosclerotic cardiovascular disease, heart failure with reduced ejection fraction, diabetic kidney disease. And lastly, I thank you for your attention.
Thank you very much, Professor Talad, for, as usual, a wonderful and crystal clear presentation. I don't see.
ربنا يخلي حضرتك يا بيه.
الله يخليك يا حبيبي، سلم ايديك.
ربنا يخليك.
I don't see any questions. I would like to thank Professor Amara and all the organizing committee for this wonderful event. I also thank all the faculty members, the panelists, the lecturers. I would like to thank ICOM and the technical assistants, and I would like to thank the audience. Thank you very much وكل سنة وانتم طيبين.
كل سنة وحضرتك طيب أستاذ سمير، والله
كل سنة
ينور
وحضرتك
دكتور
طيب يا
طلعت.
بيه.
الله ينور
يخليك
دكتور
دكتور
طلعت.
أيمن.